Hi, my name is Lisvel Matos. I'm a third-year PhD student, a Margolis scholar, and a Margolis summer intern. And today I'm presenting our poster, Health Policy Recommendations to Address Systemic Barriers to HIV Prevention in Black and Latinx, Gay, and Bisexual Men. HIV prevention methods such as pre-exposure prophylaxis, or PrEP, are out of reach for Black, Latinx, and other marginalized communities. In 2019, Black and Latinx GBM accounted for nearly 50% of new HIV infections in the United States, but they were less likely than their white counterparts to use PrEP. PrEP is a once daily medication that reduces the risk of sexually transmitted HIV by 99%. Currently, there are two FDA-approved PrEP options, Truvada and Descovy. Truvada was the first to market in 2012, and Descovy was recently approved for use in 2020. A key goal in the HIV National Strategic Plan is to increase PrEP coverage in populations at risk for HIV from a 2017 baseline of 12.5% to 50% by 2025. However, systemic barriers drive the excess burden of HIV among Black and Latinx GBM, as well as the disparities of PrEP use in these groups. To achieve a 300% increase in PrEP equitably, it is crucial to understand the systemic barriers that produce patterns of exclusion of Black and Latinx GBM and restrict their access to HIV prevention services and within the healthcare system. We outline systemic barriers to PrEP use among Black and Latinx GBM using three important contextual factors that determine health: availability, accessibility, and acceptability. And we conclude with important policy recommendations. PrEP availability. Although HIV is a public health problem, solutions for HIV prevention are typically found within the healthcare system. There is a lack of publicly available PrEP clinics, particularly in areas most burdened by HIV, such as the South. This lack of community options has required individuals seeking HIV prevention care to do so within the primary care setting. However, there is evidence that primary care providers are hindering PrEP scale-up efforts through lack of knowledge and reticence to prescribe PrEP. In 2015, less than 20% of providers were familiar with CDC guidelines for PrEP. PrEP accessibility. The cost of PrEP is prohibitive, ranging from $1,800 to $2,000 a month. In addition to the drug costs, ongoing surveillance is needed for counseling, testing, labs, and monitoring for adverse side effects. Although Truvada has gone generic, Descovy, which has a safer medication profile, is not. Uninsured and underinsured individuals have options to receive PrEP through the drug manufacturer Gilead's Advancing Access Program, which covers the full cost of Truvada. However, this program does not cover the quarterly follow-ups with healthcare providers and labs, which is an out-of-pocket expense for patients. Also, in January 2022, Gilead is going to reduce the coverage of compensation for PrEP by half. This is going to have a detrimental impact on safety net clinics in the community that rely on this reimbursement to subsidize the cost of routine care and testing required for PrEP. PrEP acceptability. HIV stigma is a driving force of HIV disparities, and it has trickled into the use of PrEP. And PrEP stigma has been linked with decreased willingness and decreased use of PrEP among Black and Latinx GBM. Also, public health messaging to improve PrEP stigma has been lacking, and the messaging that exists around PrEP lacks cultural and contextual relevance to Black and Latinx GBM. Lastly, we offer several policy recommendations targeting one or more of the 3 A's to improve PrEP scale-up efforts among these groups. First, create a marketplace sexual and reproductive health insurance plan similar to that of family planning Medicaid. Black and Latinx men who are most in the need of PrEP are uninsured, and a significant proportion live in states without Medicaid expansion. Next, addressing HIV criminalization laws and LGBTQIA+ IA plus discrimination policies. We know that these laws and policies are detrimental to HIV prevention efforts. They increase stigma and decrease accessibility of care to individuals who are highly vulnerable to HIV. We also recommend that existing care delivery services be streamlined as to make them more low burden for patients. So including services like walk-in visits, same-day prescriptions, and telemedicine are key to increasing PrEP uptake among these groups. When possible, moving healthcare delivery for HIV prevention outside of traditional healthcare system settings to the community through mobile clinics or using community-based organizations as a hub for care would be ideal. Lastly, we recommend robust public health messaging campaigns to improve understanding about PrEP, but most importantly, to decrease HIV stigma and stigma around PrEP use. Thank you so much for listening. Have a wonderful rest of your day.